I felt good with that one. I felt overall that I had control. Like, to a point, I'll bring up an issue later on if we get through this. I felt overall that I had good situational awareness with it. That's probably the best way to say it. That's how I felt with that one. I was proud that once I reached a point that I felt it was safe to task out the assessments, that I was able to do that and then identify the organic cause, or a potential participant of organic causes in the hypoglycemia. I felt that was good. I felt my team management QAS personnel was good. So they're the big points I took out of it. My biggest concern was recognising the realism of it. Like, you prompted me, would you still be in the room if this patient's behaving like this? Like, hell no, no way in the world. And then you kind of said, well, make it real, leave. So that's what we did. But in the process of doing that, I commenced a bit of my brief with the police officer, but then without sort of control, I didn't even really get a chance to do great assertiveness on it. I sort of turned around and I was walking out the back door to get out of the building completely and complete my brief, and my copper was gone. So I even said to the girls who were in here just before, I said, look, if that was a real situation, a real job, real world, and without being disrespectful, if I had a patient that was of potsy size and stature, behaviour as SAP plus rare, and I had a single police officer there, we're standing on the street until we get more police. I'm not even dealing with that at all. That's my thing. So my biggest reflection as we get through this is I graded myself down. While I wanted to sit there and say I was of a sound level with my ACP or my QAS crew, that initial 2 minute, 3 minute situation where the copper, where have you gone, and was in the room, I didn't like that.
And like I guess you've got the single officer there. Part of that is that if a patient's walking towards that single officer in an agitated or threatening manner, the police officer is trained to respond to that situation. That's either going to be tactically withdraw or engage and commit. And I think your police officer engaged, committed, and then restrained that patient, which is kind of like a reality of an ABD, is that you're either going to have the time to fully brief your team, or your brief's going to become interrupted due to the reality of the situation in front of you. So ideally you'd want more people on the team, and I just, we didn't say, we made an allowance for that SIM setup to say, listen, we think you would have been out of that door, but just remember that in a simulation land, like, if you don't feel safe, you should be well outside.
And I think initially, I don't know if it was caught too much on the camera, well, I didn't hear it. I made the clarification, and you verbalised it, that I'd walked into the residence because the ambulance crew were on scene and were in the residence. I was briefed that there's no police on scene yet. So I walked in and I recognised the girls were down in the corner of the room and was like, nah, get down here, get down to the doorway, so we've got a quick exit.
Oh, that was good.
But then when he was sort of getting up, I did recognise that he was in an isolated room. The room was going to be to a point some distance away, and there was an open doorway between the two. So my threshold in that situation is the moment he's engroaching into the vessel or the room that I'm in, I want to withdraw out of that. That would be my plan in that situation. So my plan, like I've written on the back here, practice realism, don't feel safe, leave.
Absolutely.
It's the situation that if I'd labelled my plan and verbalised that, perhaps I needed to be a bit more clear on that. It would be, he'd come into my room now, he's no longer in his room out the back where I can see him from a distance. He's in my room, let's get the hell out of this building.
And the pop assessment's changed. We've got someone who's seated and you know, not making any threatening postures or but as soon as he stands up and starts walking, that's the dynamic process of the pop assessment. You go, no, there's imminent risk here, we need to get out of there. So we made an allowance for that, saying that that was a little bit of simulation set up, that we had that door closed, but in reality, you need to get out of Dodge. Cool. All right, let's go through each element. So, clinical knowledge.
Some of those ones I've found during the SIMs, they're difficult to truly get and grasp on because you can't perform the assessment until quite late in the SIM. But I've marked myself independent on that, in that once I'd stepped through my process and I'd recognising that decreased SATs would progress down, I repositioned him in the lateral position, and then I tasked the assessment, and then I recognised the hypo, labelled it, and tasked the treatment of that. So I marked myself independent in that one.
So we've said assisted in that area. I think your management of the ABD as a pure ABD, good. So you kind of said, listen, this is a volatile situation. We've got a plan. We didn't see a checklist. We didn't see something to go through and give you a bit of a prompt to walk through and say, you know, what do I need to do next in the setting? But the assisted is not up at the independent range, because one of the realisations within that setting is that we've got an ABD patient, and what are some of the organic causes that we want to be looking for. It was reactive within the SIM to check for the BGL and then identify the hypoglycemia, whereas there's opportunity within that, and also in your hypoglycemic kind of CPG, where it talks about your hypoglycemic patient may demonstrate bizarre agitated behaviour, may resemble an intoxicated patient. So that's part of the consideration while you're treating down the ABD pathway, to start to think about what are the organic causes there and how are we going to treat an organic pathway if it's apparent. First of all, look for it and then start to treat down that pathway. All right, QAS policy knowledge.
My biggest one with that one, I've marked it as assisted, is when I was tasking the girls at the assessment phase, I think I should have tasked the BGL sooner.
Yes.
Sooner. It was done,
yeah.
But for me, I'd task the O2 one with get the entitled one because we've got a sedation situation going on. My patient is SAT scores deteriorating. I got a temp, but then I had an ECG put on. ECG is an important factor, but the BGL had more priority. So that for me, I've marked myself an assisted in that one.
So we've marked you down in the next column down independent for that reason too. That BGL or hypoglycemic pathway and QAS knowledge of ALOC or agitated bizarre behaviour warranted a BGL as quickly as we could when it was safe to do so. And within that setting, there was opportunity after droperidol had been achieved and restraint had been achieved to look for that assessment, to get that assessment done.
Before that sort of got to the zero, is that what you're suggesting?
Well, the SIM pathway demonstrates a patient who's at SAT +3, then they go to a SAT +2, but they don't go past a SAT +2 +1 in the restraint process, because part of the reason for them being agitated is and bizarre and acting out is they're hypoglycemic. So the SIM is designed to say, yeah, we need to use the checklist to identify, manage the risk, and then manage the reversible cause as quickly as we can within that setting. So that's why we put the dependent in that area. Comment or discussion?
No.
Safety manual tasking, PPE, infection control.
I marked myself as independent on that. I recognised that Courtney didn't have glasses on. I took the sharp bin with me,
yep.
And I verbalised in the contrary to the last time I did it, my zone of attack. And I was also very aware of my situational awareness, which again I'll talk about later, in briefing the girls
yep.
with where you are and what you're doing and how you're approaching and where you're standing.
Yeah. So similar again, I think your approach to the sedation, moving them out to the doorway and away from the corner of the room, very good in terms of scene setup and situational awareness for safety. We've given you assisted in that area, and the rationale for the assisted within that area is that your approach to the patient, while much improved from similar SIMs in that area, is still approaching near the legs that are not being restrained at that time. So we've spoken about
approach.
Yep. So approach around the back of the patient, or management of your team just away from those areas. And I know that you did the management through to the door and then an arc around the patient, but then the approach to the patient for mine needed to be just considerate of what are the big levers in that setting.
Okay, I wouldn't have thought I went any further south than what the valley umbilicus was.
Okay. Well, I'm happy to have a look but that's the review and.
Well,
and something
assistant is where I want to be, but you know, it was just
history taking.
I marked myself as assisted because I did task Courtney to look for any obvious key things in the home or in the immediate environment.
That was good, I thought.
I did verbalise that before I'd even got to Droperidol, do I see anything on my patient? Am I looking at Medi-Alert bracelets and I'm looking at things like that that's going to paint a history to me? Now, the patient, when I did try to interject some communication, was still a SAT +3, and you know, his behaviour, I guess, wasn't exactly cooperative or coherent. I think recognising I should have done the BGL earlier with the QAS policy of knowledge, I'm still happy with that being marked as the system. I think I implored that rather than just making the assumption that this is an ABD.
Yeah, so your history taking within your independent, you looked for markers like your Medi-Alert bracelets. You tasked someone to go and have a look around the house or for anything that may have indicated there. And beyond that, you really couldn't get much out of the patient at all. So for what you could do, you achieved the maximum within that setting. We had a little bit of a discussion about was there more opportunity to get more, and the result of that was no. Like, given the situation in front of you, you got as much history as you could from the scene and from the patient, and then you just had to manage the patient. Physical exam.
I never completed a head to toe.
Yep.
But realistically, even when I watched the video, I allocated myself, and there's two conflicting thoughts in my head at the moment, and again I'll talk about that later. I allocated myself as the airway clinician, and duly recognising, even in my reflection writing on the back, I had a student observer and an ACP and myself. I think that was the best place for me. It allowed me to have situational awareness and an oversight and an overview on it. I had the girls busy the whole time, and I really don't know if that physical examination, exposing and looking, was ever really going to be within the video time frame that was there at 20 minutes. I don't think it was ever really a permissible thing to do. Again, up into the history taking, I looked for Medi-Alert bracelets and I looked for anything there. So I've marked myself as an assisted in that one.
So, agree, you looked for the Medi-Alert bracelets, didn't see a complete head to toe completed, and also within that setting, the exposure of the patient is still enclosed, and you know, like patient's roll on the back, there is an opportunity to pull up the shirt and have a look at the skin. The other thing that we didn't hear verbalised was, here's my RABC, here's my primary, and here's my going back and having a look at my RABC. So in terms of physical exam, and it comes into your systematic approach there, while care was being treated to it, the physical exam elements weren't being completed. And then if you look down the patient and you review the physical exam, then you're going to get cues that may point you in the direction of, hey, is this patient just flushed and hot and dry and lashing out, or is my patient, you know, got poor vasculature? Are there signs that they've got cool peripheries? Are there signs that they're cool and diaphoretic, which may point you into the, am I treating, say, that hot flushed, agitated patient, or am I treating someone who's pale diaphoretic and may have an organic reason down the pathway of treating down that pathway? So systematic exam.
I said myself as assisted, and while I might not have verbalised it, my patient was positioned in a lateral position. I verbalised that there was, okay, there's a stridor there or a snore there, and I reached for an MPA. I applied a painful stimuli and tried to determine a GCS. I checked for my carotid pulses. I didn't do a rate, rhythm and effort on the respiratory, but I marked myself as assisted, that even at times when I had the girls being busy, I went back and again went, what's my airway? Is my airway patent with the MPA? And you said at one point it's how you find it. And then the other one was, I applied a painful stimuli and determined that, you know, you got a groan from painful stimuli and things like that. So I found that my systematic approach I might not have verbalised as much, but I did feel
You were
that
thinking
I acted it out.
systematically. Yeah. So we've given you a dependent in that range, and one of the reasons for the dependence within that area is the late vital sign survey within that setting, a complete vital sign survey. I don't think we got a blood pressure until very late in the piece there. But regardless of what the individual elements of that vital sign survey are, that system of going through and where are we at with our RABC, and then where are we at with our vital signs to see if we're ticking along. So the pickup of the VGL, and as the SIM was written, I did treat hypoglycemia, glucagon or glucose 10% with good recognition of differences on onset and effectiveness. Post sedation, which you provided, patient will become GCS3 and remain tachycardic and sweaty if BGL is not checked and corrected within 15 minutes. So we identified the hypoglycemia around the 12-minute mark, and we didn't get fluids or glucose running until about the 16-minute mark.
That comes up later on.
Which is late in the piece. And like with your checklist, I think you'd be honing in and going, right, now my patient's in a lateral position, restrained, and has the droperidol. Are there things we can do within this setting to look at? Is there an organic cause? Is there something that we can do within that setting? So,
actually, so much so, if you looked at the value of the hands that were on the scene, we've talked that in that concept, and had the uni student and gave us some clear examples of what you wanted to do, exact head positioning, you know, whatever airway support you want, watch the monitor, this is what I want you to do. She would have done exactly that. You might have got away from the head. You could have got the checklist out. You could have even had your CPM out if you really, really wanted to, and just had a look through ABC.
This is where I've torn myself apart watching the video, and I found myself, I've written comments, established crew mix and skills coach is it going to permit better tasking, and then delay in IV access for query a role change before more skills myself. And I've written that there already.
Well,
but my counter argument to that was, at the head where I was when I was sitting there watching the video, I had that oversight, I had that overview. I was able to sit there and go, do this, do that, I want you to do this, I want you to do that. Oh, you don't know how to prepare your glucose 10%, right, I want you to swap roles. Whereas I was feeling from that position, I had that supervisory oversight. And if I'd gone and done the cannula, I might have got the glucose in at 13 minutes or something like that. But I also sat there.
No, but you know, the tasking, you know, I mean, realistically, if that was a real job, she would have struggled cannulating that patient, and being a uni student, there would have also been a risk of her getting assaulted as well. You know, she's just got no situational awareness at that age, at that, you know, work age I was talking. So, you know, even the tasking there, you could have stood there and drawn the glucose up yourself while Sarah got the IV and she's on the head, and then Sally, and then you've got that step. You just disengage from the patient. Do you know what I mean? As much as you can. So.
I felt when I was watching the video that I had that oversight and that control, rather than going and performing a skill and doing, this is what I'm doing. I'm now not watching that. I'm not seeing them on. I can't see the monitor or do whatever.
Yeah,
so that's where I positively reflected on leadership of the scene. I thought that
the position of where you should be and what you should be doing changes from simulation to simulation, job to job, really. You know, and we don't always get that right sometimes too in reflection, but I guess in reflection for that case, you know, you could have actually had your most menial task, which is the airway. In this case, you know, airways can be difficult, but you can actually still stand back and draw up glucose 10% and still watch the monitor and still watch the scene. And you know, because if you do the IV, you will lose your situational awareness. Not to say that in that case, if he's really, really difficult, you might have to lose your situational awareness and put the IV in and hand the job over to Sarah for 5 minutes.
I think it's part of the mix of learning how to be that CCP, is learning how to maintain the veranda view, the situational awareness, and then dive in to do a skill that needs to be done in a timely fashion or within your scope, and then come back to that brand of view, well, that's
Because I've already reflected